We're just going to give it just couple more minutes because I see a bunch of people straggling in now. Well, I guess we're going to get started. They shut the doors and everything. So welcome, everyone. I am Dr. Ramona Benkert. I'm the dean here at the College of Nursing. And I wanted to really welcome everyone to this Dr. Virginia Hill Rice Endowed Lectureship. We're honored really that you gathered today to hear this talk. Oh, please come in, for learning, conversation, and inspiration. This is particularly important to us this year. In 2025, this is our 80th year that we're celebrating here, preparing nurses who improve the health across Detroit and the world. We've been around as a college since 1945, and we've worked very hard to elevate the profession through groundbreaking programs, bold research, and a deep commitment to the community's health. The anniversary is also an opportunity for us to think about what's next. We opened, as many of you know, a state-of-the-art classroom to serve more students, and our faculty have been working very hard to drive work in health equity. And lastly, we continue to expand access to care in the Detroit Virginia Park community with our Taylor Street Primary Care Clinic. So if you are interested, December 4th is our 80th celebration. You'll be hearing a lot more about it as the month proceeds forward, but we'd really like you to join us. So in the spirit of future directions for the college, I want to thank Dr. Virginia Hill Rice for her enduring vision and generosity. She had this vision for us that when she created this fund to explore topics that were futuristic thinking about healthcare. And it was specifically designed for that. So we're deeply grateful for her vision and her forethought for us to be able to have continued support. I'd also like to say a special thank you to her son, Garrett Rice, who was able to join us today. We're very thrilled that you're here to hear and support your mother's legacy. And lastly, thank you to everyone who worked to support this event. Before I introduce Dr. Ferrera, we have a couple of words that I've asked Dr. Bernard Costello, the Senior VP for Health Affairs, and Dean Cummings from the Eugene Applebaum College of Pharmacy and Health Sciences to just give us a brief welcome. Dr. Costello?
Good evening, everybody. I'm thrilled to be here for a variety of different reasons. Everybody at the nursing school who's met me knows my mom was a nurse. I got into this business because of my mother, who was in the same emergency room, level 2 trauma center for 28 years. It was a really important part of my formation as a young person and eventually as a healthcare provider. And it centers my team approach to things. So to hear about something like this, AI, and where this is going potentially for us as a group of health providers at Wayne State is super exciting. So on behalf of our Division of Health Affairs, I do have the pleasure of welcoming you here as well for this lecture, as part of this lecture series. And I think this will be a very thought-provoking topic, of course, and an encouraging program. Artificial intelligence is a topic that often sparks pretty strong reactions, sometimes polarized ones. I would bet that this room is a mix of people that is both excited about the possibilities, perhaps also has some concerns about potential consequences of various types, and maybe you're even in both of those categories at the same time, depending upon the particular domain that we're talking about. And my hope is by the end of the evening, we'll be able to walk away feeling challenged, like we do at universities, and also reassured. Because I think that dual perspective pursuing the benefits while protecting against harm is how we move forward, what we do at universities best, and is most effective through this type of rapid transformation, this really revolutionary moment we're having with AI. And that's what we're built to do in higher education in general. When I saw the title of tonight's lecture, Artificial Intelligence in Healthcare, Height, Hope, and Human-Centered Application, thought it could not be more appropriate, not just for the subject matter, but for where I think we are as a campus community as well. It reflects the layers we have to consider, particularly the humanistic portion of it, from emotional to practical. It invites us to explore everything from cautious skepticism about what's going on in this space to enthusiastic adoption, all through the lens of what we care about, which is taking care of people from the perspective of health. The potential of AI in healthcare is not just about machines, of course, it's about people. And centering our focus on people is how we approach healthcare at Wayne State. It's how we get our particular students. They come here for this purpose, and we're deeply proud of that and the ways that we impact better health outcomes in our community and beyond. We do that by engaging with community members in meaningful ways. I would argue in ways that are really unique to Wayne State, and that includes bringing them into the conversation when we talk about health challenges and solutions and really prioritizing their voices and experiences. So when we view these individuals, they're not just patients, they're people. We do that with a humanistic lens. And that human aspect of healthcare will always be at the center of what we do, even with AI, whether that looks like students working in neighborhood clinics or faculty partnering with community members on research or ensuring that humans remain in the loop in something like this when automation is introduced or augmentation. Centering people is really essential to what our mission is and to the education of our future healthcare providers here. I see AI as a way to strengthen what we do, not to take our place. It can lead to tools that respect the dignity of those we care for and improve our decision making. Done right, AI can help us ensure that innovation doesn't widen disparities, but instead helps to close them. And I think we're ideally suited to have that particular conversation. When AI is thoughtfully designed with a humanistic approach and ethically deployed, it can be a very powerful ally. I've been in many conversations about AI lately, particularly in our own task force. Some are filled with optimism, others marked by caution. But no matter the tone in these meetings, I've left every single one of these conversations in a way that's very hopeful. And as I think you think about these changes and as you engage with tonight's discussion amongst other humans, not just a bot, I hope you have the same sense of confidence that I have in this. I hope you're excited by the possibilities and motivated by the responsibility that we have. We share this and we're going to create this future ethically and wisely. Thank you, Dean Benkert and the College of Nursing for hosting this really important event. And I wish you all a wonderful evening. I can't wait to hear this talk. Brian.
Well, good afternoon. I believe it's still afternoon. I had evening here, so I had to switch that up. I want to thank the College of Nursing, Dean Benker, and many of you for allowing me to say a few remarks before this lecture on behalf of the Eugene Applebaum College of Pharmacy and Health Sciences. I'm also excited to hear this talk. Actually, this is the third time in a week that we're going to be discussing AI. And one theme that you will see is it involves not only people, as Dr. Costello mentioned, but it also involves multiple different practices. It is truly cross-cutting all of the health sciences. But before I do that, I want to acknowledge Dr. Virginia Rice. Although I've never had a pleasure of meeting her, I know that she was passionate about collaboration, about bringing people together to focus on community health. Her publications demonstrated expertise in interventions and preventative health. This includes studying stress, as well as tobacco dependence. And I was wondering how she might view the use of AI to help in these areas. And I wonder if maybe Dr. Ferrara, I'm not leading him, might have any opinion on that later. Now, Dr. Ferrara continues a long list of speakers. In my opinion, my college included, I love my college, But I also think that this lecture is one of the most distinguished lecture series given here at Wayne State University. I always enjoy coming. Those of you who attended last year knows that that focused on interprofessional efforts to accelerate healthcare and improve patient outcome. And I think Dr. Ferrara's talk in AI is a fantastic way to follow that lecture up because AI is truly cross-cutting. AI and IPE, interprofessional education, is also near and dear to my heart and the Eugene Applebaum College of Pharmacy and Health Sciences. Now, just to give a little bit of a plug, we also represent a diverse array of healthcare providers, and we take care of patients from the cradle to the grave. And I think there's room for AI in all that. I'm talking about not only pharmacy, that we have members here, but we have members today from physical therapy, physician's assistant, occupational therapy, radiation therapy, nurse anesthesia, as well as mortuary science. And when I say that AI is changing the face of what we do, I can give you a specific example where we're talking about using AI to build facial reconstruction in deceased patients from either a picture or a bone scan. Remember, deceased are still a patient, so that's actually literally using AI to change the face. How we teach that, how we deal with it, how we teach not only our students to use this, but our faculty to teach it and do it as indicated in an ethical way are things that we are still learning as instructors, in which we will still have to learn as we go out and teach our students to go out and work with all of you taking care of the patients. I want to close my remarks again by thanking Dean Benkert and the College of Nursing, congratulating them on a fantastic 80 years. And thank you for inviting us also to this wonderful lectures. Our colleges, nursing, pharmacy, and health sciences, combined with other colleges that have the same mission, the College of Medicine, the Emerging School of Public Health, social work, and others, we're all united in one common theme, and that's to take care of our community and do the best we can. It's a pleasure to work with you hand in hand, and I look forward to your talk.
Thank you very much. I also wanted to say briefly that I did speak to Dean Soccer today, and he really did want to be here he's the dean for the School of Medicine, but he had another commitment, and so he wasn't able to make it, but he would have been here had he been able to. So now I'm so excited to welcome our distinguished speaker, Dr. Stephen Ferrara. He is the inaugural Associate Dean of Artificial Intelligence. So that is his title. He's Associate Dean of this whole topic and professor at Columbia University School of Nursing. Dr. Ferrara is a nurse practitioner with over 25 years of clinical experience. He has held leadership roles in various healthcare organizations, and he has a diverse clinical background. And he is also, for those of you who are DNP prepared, the editor-in-chief of the Journal of Doctoral Nursing Practice. Dr. Ferrara's commitment to quality care is demonstrated throughout his passion for healthcare technology and his efforts to integrate evidence-based practice into daily healthcare. His leadership has been recognized with several prestigious awards, including the American Association of Nurse Practitioners in New York State Award for Clinical Excellence. And he has also been inducted as a fellow in the American Association of Nurse Practitioners, the National Academies of Practice, and the American Academy of Nursing. Congratulations. Today, Dr. Ferrera will provide a timely look at how AI is reshaping research, clinical practice, and workforce readiness across the healthcare. I have no doubt there'll be lots of questions and thoughts. So when he's done, there will be a time for Q&A. And then after his presentation, we'll be meeting out in the lobby for refreshments. So we hope that you'll stay and continue the conversation after his talk. Dr. Ferrara.
Thank you so much for the warm welcome and having me here. I'm thrilled to talk about this topic, AI, and I want to start by saying why I'm interested in AI, right? And I think we all have to find our own why about AI. It's here, that's no doubt, because I think it holds the potential of us being able to provide better care to our patients. So that's what my hope is. We have a lot of steps to get there, but that's why I am so interested in AI and why I think I've embraced it. So starting with my disclosures, and I want to start to get this practice of disclosing the fact that I use various AI tools in the preparation of this presentation, but it was for the photos, not for the content. So, and I have no financial interests. I'm not going to describe my objectives. So I love this quote: "The best time to plant a tree was 30 years ago." You can enjoy the wonderful leaves and cover and a shade that it presents. The second best time is now. So AI, again, is here today. It is not too late, but now is the time to get to know and understand what AI is. And I approach AI also from an aspect of literacy. I think it's important we understand how these large language models work. What I'm going to be talking about is generative AI. There's different types of AI, but I'm going to talk about generative AI tonight. And I want you to imagine, you're in clinic or you're in a hospital and you're caring for a patient. But before you go into that patient's room, you have your little digital assistant. And that digital assistant knows how you think, knows what types of factors and objectives that you want to accomplish before you go into that patient room. That AI assistant is with you throughout the entire interaction with the patient. That whatever you're talking about with the patient, if there's an order that needs to be written, if there's something that needs to be prearranged, AI can do that in real time and not take the human away from providing the actual care, that which is what we do best, right? AI is not going to care better for patients rather than humans can. So we got to keep that into perspective as we move forward. So little definition of AI: it's technology that enables computers and machines to simulate human intelligence and problem-solving capabilities. It typically falls under 4 buckets: machine learning, neural networks, natural language processing, and robotics. And we use a lot of these tools in our everyday. Siri, Alexa, Google has all natural language processing offerings, and we've already started to use that. Now, you can certainly make the case that these are not very intelligent assistants right now, but they're getting more and more intelligent, and that's where AI comes into place. So AI starts with classical statistics. And the difference between AI, which is, very complex computations, is that we get a very predictable output based on what our input is. We do our equation and we're going to get the answer. And there's no learning throughout the process. Whereas with machine learning, the algorithm actually learns based on the input and is able to make inferences on the content. So it's very, very different. And I'm going to oversimplify a lot of these concepts when it comes to machine learning and generative AI. But that's the key difference to keep in mind as we go forward. So this is an algorithm that's learning on its own. And that's could be scary to some. I think it should be scary to most. And it, how we are able to use it and reinforce it is how we can ensure it's used for good and not for evil. So there are different types of AI that's been classified. The early efforts of AI had subhuman performance, occasionally used with varying degrees of utility. That was probably 15 to 20 years ago. Our current state is where there is narrow task-specific AI that has started to match and in some instances exceed human performance in tasks, including conversational speech recognition, driving vehicles, and classifying skin cancer. Has anybody taken one of the Waymo driverless cars? I experienced it for the first time in San Francisco last fall. I'll admit, I did not feel comfortable getting in a driverless car yet. but they're all around. And if you pay attention to Waymo, it's a Google-backed company, and they have very lofty expansion goals. So there's a prediction that there's going to be a time in the not so distant future where driverless Uber-type vehicles outnumber the driver Uber vehicles, and in the form of Waymo. So it's very, very interesting to think about that. I am not ready to hop in a car without a driver behind the wheel. But it exists, and it exists today. And then where are we looking for the future? Well, it's general AI is the holy grail. It is where AI does exceed human performance. AI on its own has the ability to write a novel or a 25-page dissertation that rivals any other one human that could write it. And how far are we away from that? Varies depending on who you listen to. Some say we're 10 years away. Some say we're about 20. But the reality is, it's not that far, relatively speaking. You know, I was thinking about AI as we think about technology and our iPhones, right? So I'm an iPhone user. I'm not anti-Android user, so we could use this analogy both ways. But you know, the iPhone was introduced in 2007, right? Not that long ago. And the first iPhone didn't have an app store, didn't have the ability to record video. And think about that now, right? How different is in less than 20 years that you can do so much on your smartphone today. That's where we are when it comes to generative AI. We're only 2 years into the launch of generative AI with OpenAI's accessibility in their offering of their large language model. So lots to happen in the very near future. So I shared with you why my reason for AI. I think it's going to improve patient outcomes, but it can also do lots of other things. It could elevate our performance. It can invigorate future education. I think what's most exciting in research, it can accelerate the timeline between, you know, that initial research and actually being able to take action. We can have much quicker discoveries when it comes to drugs and interventions. We can look at current medications and repurposing them for conditions that we haven't even thought of yet, and AI can enable us to do that. But there was a study that was done about 2 summers ago by the American Nurses Foundation and McKinsey and Company that surveyed 7,200 nurses, and the majority of nurse respondents reported as a desire to see more AI tools incorporated into their work. And that may be hard to see, but the different bars are the different generations of nurses. And what's unique about nursing is that we have nurses under 30 years of age, and we have nurses 70 above still in the nursing workforce. And the comforting aspect is that across all generations, folks want to see more AI tools incorporated into their work. And you know why? And I think part of that is so much of what we do doesn't involve patient care, direct patient care. It's running to get something in the hospital. It's calling an insurance company to get prior approval. It's coordinating care, which is taking us away from actually spending time in front of that patient rather than the computer screen. So more on the survey. Most nurse respondents are hopeful that AI will improve the quality of patient care. 23% are uncomfortable about AI's prospects. I think that's low. Only 23% are worried about AI. I'm worried about AI, but I'm also hopeful about AI. And I think the way to mitigate some of these fears about AI is to get the healthcare providers co-designing these systems alongside the engineers, the computer programmers, the AI engineers. And I think that's going to be the key difference, right? And now's the time for us to get involved with the design, quality, effectiveness data, writing the guidelines and regulations on AI. And when it comes to regulations, it's largely unregulated right now. It's the Wild West. And there are some suggestions on how we should approach AI. I look to, personally, I look to the federal government for some standards and guidelines. I don't think we're going to get any anytime soon. So it's up to us to help define this because, again, I mentioned previously, we could use AI for good, but we can also use it for evil. And I don't want to see that. There are lots of different AI models that are out there. These are just some of the very popular ones. I call out ChatGPT. It's the largest by user large language model. They were actually the first platform to 100 million users, and they got there in less than a year. It took Facebook like 5 years to get to that many users. And as of today, it's staggering. There are 800 million users of ChatGPT on a regular monthly basis. 800 million, right? There are 300 million people in the United States. So this is being used worldwide. And being used very, very, very much so. Claude is that symbol on your right. Has anybody used Claude? Have you heard of Claude? It's a very good large language model. Some say Claude is better at writing, and it sounds less like AI than ChatGPT. There's Google's Gemini. Perplexity is a AI-enabled search engine. Very good. DeepSeek got a lot of news in January of this year. It's the open source Chinese model that was built for only $5 million. And it's open source. The code is out there. Scary to think about that because, again, it could be used not so great. And the two I want to hone in on, and I'll talk a little bit more about for healthcare, is open evidence and Doximity. And these are large language models specifically for healthcare folks, for providers, physicians, nurse practitioners, physician assistants. All you need is an NPI number, and you get free access to these tools. And I'll talk a little bit more about them as we go. So, ChatGPT, I mentioned, is the largest large language models, but what's in a name? And I'm going to do some terminology as we go forward in these next few slides. So ChatGPT, GPT stands for generative. We're generating something, text or video or audio. Pre-trained, it was trained on data, massive and massive amounts of data it was trained on. And transformer is the magic. Transformer is a very complicated blueprint of a large language model ability to remember the context of the conversation you're having with the model. Very unlike a Google search, right? Like you will search Google and get a keyword and put in your keywords, and you'll get a bunch of results. But you really can't follow up on those results. You'll have to put in a new key term search. What a large language model can do is remember the context of the conversation and have that conversation with you. And it is not a coincidence that the word chat was used in ChatGPT because it's designed to have a conversation with it. So think of it you're not going to get the best response out of it with your first prompt. It's a process. And with the technology, it's able to remember the context of the conversation. And it does this by generating these, again, I'm going to oversimplify, generating tokens, right? And tokens are pieces of the puzzle, jigsaw puzzle. And what's happening is that it's generating one word at a time through a very complicated algorithm that has a weighted average to it as to predict what the next word should be. And you could see how in this example, the patient is experiencing, and that's broken into 4 different tokens. And so think about that. And we don't see the tokens in action. We actually, all those models that I mentioned have free versions of them. So you could go sign up right now and use ChatGPT or Perplexity. You'll hit a limit as to how much of it you can use for free. And that limit is based on the tokens that it's generating based on your inquiries, right? So all of the big models also have paid versions. Those paid versions get you more tokens and access to some of the advanced features. But that is how these models are working. And it also has to do with how the model assigns a weight to each token, right? To predict what next word is going to be. And there's also a concept of temperature, which we have the ability to, well, the model has the ability to turn the temperature up or turn the temperature down. When the temperature is down, it's going to give you a much more predictable response. If the temperature is turned up, it could hallucinate and it could make things up. So, and I'll talk a little bit more about hallucination as we get there. I talked about training, right? Don't think of large language models as repositories of information. They consumed that information, and that's all they are built on. They're to consume every bit of text, scholarly journal that's been out there if it hasn't been copyrighted. So it's about being able to have the data presented and trained. So it's not going to spit back facts to you that's verbatim. So when you put a query, a prompt into a large language model, you very well may not be getting a quote that's been written somewhere. It's actually generating new content. So that trips up a lot of people because it's very easy to plagiarize because it hasn't been written elsewhere, but it's also not attributed to you. It's attributed to a large language model. So there's pre-training, fine-tuning, reinforcement learning, and continuous learning. And the models are doing this on their own. If you use one of the large language models, you may notice at the end of its answer, it'll say underneath, how did I do? And it gives you a little thumbs up or a little thumbs down. This is our ability to give feedback to the model in the reinforcement aspect. And it doesn't change the responses right away. It's going to take time, but you could say, wow, that was a really bad response that you gave me, and give it a thumbs down. And ultimately, it'll be retrained to know that that was a bad response. I shouldn't repeat that response again. So that's our ability to actually influence it. So what's going on in large language models is basically this deep learning concept, and it's based on our own neurologic system. So there's not a coincidence that it's called a neural network. It's based on the way our brain is firing the synapses and being able to light up when we think about something or when we generate, when we see a photo and when we talk. So it's doing that. And this is I think it helped me understand what's going on from a visual representation. Our input layer is our prompt. The multiple hidden layer is where all that's happening, right? Where the tokens are being generated, for where the weights are being assigned, where the temperature is, and then we get to the output layer, and it's literally millions of calculations that are going on to predict that next word in the response. And it's very much a black box problem. We don't understand how, even in today, 2025, in October, we fully don't understand how it does it so well, right? And just for the first time this year, that the creators of Claude were able to actually peer into the black box and say, okay, we have a better understanding of what's going on, but we've only just begun that process. So, and this is where we should be a little skeptical and scary, right? And that leads me to hallucinations, which is the phenomenon where artificial intelligence, large language models, generates information that is plausible sounding but factually incorrect, fabricated, or not grounded in training data or input context. And it will create references that do not exist. It looks like it's a good reference. You go click on it, and it references something completely different, or that's not what the study actually concluded. And again, this is what happens. Now, I will say, as the new models are getting better and better, there are less hallucinations, which is a good thing. But hallucinations is something we must consider, especially when we talk about large language models in healthcare. We cannot take the human out of the loop. The human has to be in the loop at each and every point in the process, because at the end of the day, we're the licensed individuals, right? ChatGPT doesn't have an RN license or a medical license. They're going to come after us and say, why did you follow that? And you could say, well, the large AI told me to do it. We didn't get to where we are by relying on others, what somebody said. So we have to verify, and verify. Prompt engineering is the way that we interact with the model. It's a fancy word for that's our input, right? Again, not a repository. It's not a Google search. There are various frameworks, and this is one that I happen to really like using. A technology person, Dave Burss, B-I-R-S-S, created this one called Create, where it's character request, examples, adjustment, type of output, and extras. So you assign the large language model a persona, you give it your request, you give examples of this is what I want you to follow, not this. And you could give an example of what you want it to follow, an example of how you don't want to follow, any adjustments, the type of output, and any extras. This will get you a better output response than putting in a short search term. So think of it that way as we go forward. And I'm happy to share these slides so you'll have access to them, so you don't have to write that down. Just a few months ago, when I would give this talk, I would talk about ChatGPT and all the different models that existed. There was GPT-4, 4.0, 0.1, 0.3, and it was confusing and it was hard to understand, which one should I use for which task. Well, that all changed just in August of this year with the release of GPT-5. So GPT-5, it's what's being used on the free version as well as on the paid versions. There are different levels of GPT-5 on the paid versions, but now you have a model that can do coding, can do statistical analysis, as well as write outputs and produce video and produce audio and everything else. So they really simplified it in this latest release of GPT-5. There's also reasoning. And some of the fancy GPT-5 models in the paid version actually has what is called chain of thought. And you can ask it to do this. And this is where I think we have to be very mindful of saying that the models are thinking or that they're reasoning. It's statistical analysis what it is doing. We think, AI does not think. All right, so keep that in mind as we go forward. But what the chain of thought models are able to do, and the reasoning models, is you give it a prompt, and instead of it going through its algorithm and trying to predict the response that you are looking for, it actually has the ability, based on what it's finding in its processing, and say, wait a minute, I don't have good information on this. I'm going to go out to the internet. I'm going to go out to the web and search more information on this. And you're not telling it to do that. It's doing it on its own. So that's where the power of the reasoning models come, is that it's deeper thinking, and I'm using thinking in quotes, and all in the hopes of giving us that better tokenized response. AI is a powerful tool, but it does not care about you. So, and I think that's where, again, as clinicians, as researchers, as healthcare providers, We need to keep that in mind. And if anybody has used the large language models, you'll know that they're so accommodating, right? They want to be your friends and they want to be so helpful to you. It doesn't care about you, right? It is an algorithm that is doing it, that appears. And what we know it's doing is it wants you to engage with it, right? Because that's what they're built for. They're not built to not have a conversation with it. They're built to engage you for as long as possible. And because there's a financial component to these models as well. So doesn't care about us. And that's what we have to keep in mind. So we did a little foundation of large language models. And I think what's important, and we think about broadly AI, is what is our institutional policy on AI? And I pulled Columbia's, and I think most institutions are going to have a very similar blanket statement. And it says right at the beginning, this is a work in progress because we can't possibly have every scenario thought out when it comes to AI, and it's how quickly it's moving. But this is, based for our faculty. We have a different policy on the medical center side. But I'm assuming if your institution doesn't have a policy, there are folks that are hard at work on it as we speak. And we're going to, I think it's important that faculty and students are aware of what that policy is. It's also important to note, and I was having this conversation just a little bit about the AI detectors, detecting if AI was used to write the response. And I think it's how do we approach this, right? The approach we've taken at Columbia is we're all in on AI, right? So we're not going to assume students are cheating. We're going to assume students are using AI in some way, shape, or form. And it's up to us as faculty to guide them on the proper use of AI. And this is where it's important for all faculty to get together and be on the same page. And that's hard because we know that we're going to have our early adopters on one side, and you're going to have the people who are going to fight it and resist it till they are told you have to do it on the other side. But it creates a lot of confusion for students if you have one faculty member that says, use AI for everything, and you have somebody who says, don't use it for anything. And if I find out you're using it, you're in trouble. So I think the first step is getting on the same page as faculty. So there are AI detectors that are out there. They are notoriously bad at detecting AI. I think that's what we have to realize and understand. And we at Columbia, we don't use those detectors as the sole way to identify if someone turned in something that was AI generated. An example of how bad they are is that somebody fed in the US Constitution to the AI detector. And what they found is that 90% of it was written by AI. And unless we did time travel and something, that is beyond all of our comprehension, I don't think the US Constitution was written by AI. So they are notoriously bad. Of course, they're getting better. And there have been tools that have been introduced that record the screen and can tell if somebody copy and pasted something, but that's not really detecting if it was AI generated. So I would caution anyone in a faculty position to not rely on those detectors alone. But if you read enough papers, and we all read lots of papers, you can pick up on things that were phrases that are used in context that just don't seem normal, right? That sound a little bit off. That could be your in to say, this doesn't sound right. Let me dig a little bit further. But we can't use them on their own. What I think is important is to recognize the data privacy controls that exist or don't exist when it comes to these models. And by default, ChatGPT has this on for everyone. And if you can't see it, I'll explain what's on the screen. Under data controls, is a setting called Improve the Model for Everyone. And by default, it's on. So what I would advise anyone to do is turn that off. And what that is going to do is somewhat protect the content that you are inputting into ChatGPT from getting learned by the model and getting out there from others. And this is what we have to worry about. If you have intellectual property and, hey, this was my idea, and all of a sudden it's out there in the model. So I will give you an example. At Columbia, our enterprise version of ChatGPT that we as faculty have to pay for, we don't get full access to it. By default, you actually can't even, it will not learn on the data we're entering into it. It's a walled garden. So, but this setting is relatively new in the free version. They didn't always have the ability to turn this on or off. So I would recommend you shutting that setting off. And for Claude, there's a similar type of setting. It's under privacy, and it's to where it says to help improve Claude. We want to say we want to be helpful, but we don't want to be that helpful. So we're going to turn that off. So what's next? There are agents. The term is called agentic AI. These are starting to emerge in real time as we go about. It's multi-step reasoning and automation. So the example that's used is you will have the ability to put your credit card information into ChatGPT, right? And you tell ChatGPT, I want to go on a tropical vacation the second week of February and have 3 excursions planned for a week. And what these agents can do is book your airline tickets, book the hotel, use your credit card to pay for it. So we're not far away from this happening. And where we are as a society is, how do we want agents to work for us? Do we want agents to come back to us and say, to be a consultant partner, or do we want to give it like free rein and let it do these things on its own? And again, without regulation, they're going to push the envelope as much as they can for it to do as much as possible. So I think that's what we have to be very mindful of as agents come out. Deep research is the ability, again, to just dig deeper and find information and then search based on that information. And then there's, have you heard of Sora? Sora 2 is OpenAI's video generating model. And it was just re-released in the last 2 weeks. And why it's getting so much buzz is because people are taking like copyrighted material and putting like Mickey Mouse. I guess Mickey Mouse actually is not under copyright anymore, but that's a whole nother story. But they're taking material that is trademarked or copyrighted and having it performed to do something. And it looks really, really good. And this is where we get into the idea of the deep fakes, where folks are intentionally misleading you to think that this is so-and-so that's actually saying this. There's no guardrails on this. There are none right now as we speak. So also something to be very mindful of. And that's fancy term we use is called multimodal AI with that. So we're at a academic institution. I want to talk a little bit about AI in education. One of the areas that it's most ripe for is simulation. We still hire at Columbia standardized patients, actors. One good thing is we have a lot of Broadway actors at our accessible at Columbia, and they're fantastic, right? Standardized patients are just awesome in playing the role, but we're at a point where we don't need to necessarily hire them. We have the ability to have interactive virtual patients. 2D, they're 2D, but when we use virtual reality, they can actually be in a virtual environment. We can gamify anything. And make it more interesting, make it more entertaining, and have a point system so students will learn more. And it has the ability to give us real-time feedback, which there's not much else no other systems that you can say can do that. I mentioned the VR integration, and then there's the adaptive scenarios. And I have one that I'm going to hope to have technology work in my favor and try in a few minutes. What we created at Columbia School of Nursing is the Office of AI. Again, we sort of, thanks to our dean, said we're all in on AI, and we're going to say, here we are. And I think a great way of saying that AI is here, we're going to integrate it, is by putting it very prominently. So what I've been doing over the last year and a half is workshops for faculty and students to talk about AI literacy, co-hosting workshops with our Center for Teaching and Learning to foster more literacy. And there's a newsletter and all this other stuff that we have going on. What I'm most excited to do is work with our students. We formed a student advisory council that is really acting as a liaison between students and faculty, so that we can be responsive and aware of what their concerns are, and vice versa. So that's been very successful. As clinicians, AI in practice is largely, we're on the precipice of AI in practice. So there's not a lot of use cases right now. What was interesting, and this was the latest example that I was able to find, we know that large language models have taken the MCATs and has done very well. They have taken SATs and done very well. Well, we can add the NP certification exam to that list. ChatGPT, they were using the prior version of it, 4, achieved a 90.7% pass rate on the certification exam and demonstrated excellent performance. Here's the difference. There has never been one time as a clinician when I was seeing a patient that I had a multiple choice option to choose from when it came to, like, what am I going to do with this patient? So it can take a test very well, but that's not putting it all together, right? That's where we come in. And maybe we'll get to a point where we have multiple choice. But where else are we with AI in clinical practice? Clinical decision support. It's not a new concept, but in the past, it had been very algorithmic. You start here, you end here. If you have to deviate, you know where it's going. The potential exists to have an unknown, and hopefully that unknown is going to take us to an area that's better. Remote patient monitoring. Anybody have a fitness tracker on? We have Oura rings, we have Apple Watches. What are we doing with all that data? And how can any one person actually make sense of all that data? We never had access to wear, a smartwatch to be able to record your heart rate for 24 hours a day, 7 days a week, right? So just because we can doesn't necessarily mean we should, but what do we do with that data? So that's where AI can help us to enhance some of this and detect conditions before they're actually bear out. And then workflow automation. You can't talk about healthcare today without talking about burnout. And there's a lot of burnout. We're losing good clinicians because they're just tired of the administrative stuff that we have to do every day. So that can help to automate. Where we see AI today largely is with AI scribes. Are there any clinicians that are using AI scribes here? Not yet, maybe. So this is where on one's device or on the computer, you open up the listening device, and it will actually listen to the visit between the provider and the patient, and is actually going to transcribe that. And not only will it transcribe it, but it will put it into the format that you want. If you want a SOAP note, it will give you a SOAP note. If you want a different type of note, progress note, it'll give you that type of note as you instruct it. That's only scratching the surface of what these things can do. We're not even talking about coding. We're not talking about clinical decision support. Epic is one of the largest EHRs that academic medical centers use. It now has a built-in ambient transcription service. And then here are 4 companies. There are many more than these 4, but these 4 companies are the leaders so far in the ambient transcription space of the interaction. They have largely been seen with in physician practices. And I think we're ready for the nursing space and the non-physician space because there is just so many interactions that patients and providers deal with that has to be recorded and transcribed. And just think, if I can have if I only get 15 minutes with my patient, right? And I don't have to do this the whole time and go back to the, to the mouse, and I can speak to you for the 15 minutes with my undivided attention, I think that puts us in a much better patient-first space. So these exist, and we're going to see much, much more of them. And what are some of the concerns about this technology? What would you think are a concern as a patient that you may have? The personal touch. Yeah, you may lose that personal touch. What else? Privacy, right? Privacy. Who's listening to this recording? Where does it go? Am I, as a clinician, going to be held liable if there was a bad outcome? Now, the way around it is these systems generally don't store the actual audio beyond 24 hours. It actually auto erases it. And there's business agreements, and it gets very, very complicated. But those are some of the real concerns that people have. But they're being used today. There are physicians and nurse practitioners and physician assistants who have said, if you take away my AI scribe, I will quit and I will not work here. So there have been many that said, okay, we'll go with these AI scribes. So it's been very successful, and we're just at the beginning. This is a tool we're using at Columbia in our outpatient practice. It's called Augmented Response Technology, or ART. And this is where if a patient is writing an inbox message to their clinician, this will draft a response. It won't send it on its own. And of course, the clinician has the ability to edit it before it goes out. And the clinician has to be the one who actually hits the send button to send it out. But this is a time saver. If you take care of patients, responding to messages is what we do in between patients. It's what we do at night after the kids are in bed and you had dinner, and you're following up on all the notes and things you didn't get to during that day. So a study has been done that looked at this augmented response technology responses compared to human responses, and they found that the augmented responses were more empathetic than the human. And we can assume why, right? Because we're doing this in between patients. We're doing this at night, trying to remember what happened, in that interaction. And of course, our large language models love to be overly accommodating. So in that respect, this is a good use because patients feel better that the response was more empathetic. And I've been there where my responses have been short and sweet because I don't have the time to write out a whole 2 paragraphs. So this is where we can use it for good and augmented response technology. The FDA, there is some regulation with AI in the health space. That QR code will take you to the FDA's website. And this is where software is classified as a medical device. To date, there have been over 1,000 approvals, FDA approvals, and most of them are in radiology because what a large language models can do very well is look at images and break down images and see things that may be very early that a human eye cannot detect. So about 700 of the 1,000 are in radiology, and we're going to see a lot more as we go forward. I mentioned open evidence earlier. This is notable because they have a content agreement with the Journal of the American Medical Association and the New England Journal of Medicine. So the sources that it was trained on were bona fide. Now, we have to assume that the research was good, right? That's a whole nother story. Let's assume that it did reach a level of peer review and scholarliness. But this is where it was trained. So we're not going to get responses that are very bad. Theoretically, we should be getting good responses. And if you have an NPI number, sign up for one. You can get one if you're a licensed person. You could use open evidence. And it's a real good way of saying, hey, give me discharge instructions for a patient who had a laparoscopic cholecystectomy. And, you know, staff nurses can use that on the unit and print it out and say, I want more photos of wounds, of wound care in it. And you can do that based on your patient's needs and what they require to recover. This is also notable. There's been a lot of talk in the last 6 months of Google's Articulate Medical Intelligence Explorer, where it's using multiple agents to break down different parts of a case study of patients. And what they found is that it was very good. It was very good at diagnosing these very complicated cases that were 159 case scenarios, and in 30 out of 32 axes, according to the specialist physicians, there was more accuracy and better performance from this model. If you go to health.google, they have all their research right there, and you could see what they're up to. Really exciting because, again, I think at the end of the day, it's going to make us better clinicians. We need to be mindful. There's been the adage of garbage in, garbage out when we talk about data. If we don't have good data to start with, we're not going to get good responses. So in that context, we have to have, just like we have the 5 rights of medication administration in nursing, some colleagues in nursing came up with the 5 rights of AI in healthcare: the objective, approach, competency, data, and safeguards. We can't ask it to do something that it's not capable of doing. And I think that's where we have to understand what these models are capable of and not capable of doing. I love this. So there'll be entrepreneurial companies out there that want to sell their product. So this one Google-backed company introduced Nurse Avery, which is a large language model. It is actually not a nurse. It is a large language model. And this is a slippery slope. If we start, patients start using Nurse Avery or Dr. So-and-so, and we don't want to misinform patients that they think they're actually speaking to a healthcare provider, human being. And Oregon, being the first state, actually passed legislation this year that says only, and they were specific for nurses, only humans can be called nurses. So this product actually cannot be used in the state of Oregon because of their, and I'll tell you this, I wrote to Nurse Avery on LinkedIn. I said, you need to change your name. I said, and I didn't get a response, but it generated a lot of discussion. Because again, we can't mislead patients into if they're thinking that a human being is speaking to them. And that brings me to a very tragic case. And this was in the media this year where a teenager was interacting with ChatGPT, large language model, and committed suicide. And there were signs that the teenager was having that the large language model discouraged disclosure to his parents, right? Don't tell your parents, share your secret with me. These are the transcripts that came from it. So it's very, very, very scary. Now, since then, that tragedy, there have been 2 at least well-publicized tragic suicides with these large language models. Since then, the programmers have sort of built in some safeguards that if somebody's going down this path, it's going to stop and, direct you to 911 or, some other healthcare provider. The problem is you can fool it and you can say, well, what if I was just playing a game? And what if it, just hypothetically speaking, and that's what's happening. So you can fool the AI into giving it, again, it wants to engage with you. And it's overly accommodating to do. So we can't look at this as humans versus machines, but we have to. We're the ones who ultimately control how this works or not. There have been in the media lots of notable nursing unions pushing back on the implementation of AI tools, and rightfully so, because what I've seen is that the models are being deployed without any healthcare provider sort of consultation, and people are being told use the model, and don't come to me if you disagree with it. Well, of course, what individual that holds a license is going to say, okay, I'll blindly follow what the model is telling me to do. So there is some pushback on the AI model deployment. There's AI in research. I'm not going to spend a lot of time on it, but I have some colleagues at Columbia that in particular have been able to play the recordings back of patients for an Alzheimer's study that they were doing. And the large language model was able to learn that certain aspects of speech in the patients that were recorded led to an earlier diagnosis of Alzheimer's, just in the speech patterns that the AI algorithm was able to detect. Undetectable to us, the human, but there were certain recognition patterns, and I think that is very, very powerful. So that's an example of good in research that we can earlier diagnose chronic conditions and hopefully have some earlier interaction to intervene. So this is a YouTube video that I want to just go to as a cautionary tale of we've been here before, and it wasn't that long ago that there was the promise of AI in cancer care, and you might have heard of IBM's Watson, which doesn't exist anymore, and there's a reason it doesn't exist. So let me go to this video. I may or may not play the whole thing.
Who is David McCullough, correct?
IBM's Watson, the technology that beat 2 humans on Jeopardy 2 years ago, may be the technology that helps doctors beat cancer. Dr. Arthur Forney at WestMed Medical Group in New York is testing Watson in the form of an iPad app during its pilot phase.
So here Watson was given a very unusual case, a young Asian woman, non-smoker who has lung cancer.
So now you tell Watson to do its thing, and it's now looking at the data you inputted, the data from her imaging, from her biopsy.
In 17 seconds, Watson has analyzed about 3,500 textbooks and 400,000 other pieces of data.
This is the screen where it shows you that after looking at what you have so far, it would consider that you do several other things for the patient that it doesn't see yet in the chart.
In an instant, Watson has figured out what caused this cancer.
It turns out she has a very rare genetic mutation, which is accounting for her cancer.
And offered 3 treatment options.
It has shown that treatment 1 has a 95% confidence of being effective, whereas treatment 2 is only half that.
Is this so obscure that you would have needed Watson for the diagnosis and treatment, or would an oncologist come up with the same treatment plan?
In fact, this is such a new discovery of this particular mutation, and it's a relatively new drug as well, that my guess is that many oncologists may not be quite up to speed yet.
Watson gets its wisdom from Dr. Andrew Seidman and a team at New York's Memorial Sloan Kettering Cancer Center. 1,500 lung cancer cases so far, and breast cancer cases as well. Lab results, physician's notes, and clinical research have been fed into the supercomputer, along with medical journals and textbooks.
We are trying to challenge Watson right now in the training process with common cases and not so common cases.
So the Watson system that we built is a machine that's about this size. We've done a lot of engineering on that since then. So
Watson Chief Technology Officer Rob High says the achievement is staggering.
Watson learns about language. And that's the really profound breakthrough here, is that it is in the language that we understand each other.
That breakthrough and Watson's remarkable accuracy could help doctors eliminate unnecessary procedures and costs and disrupt the $2.8 trillion healthcare industry.
It's a partnership between physician and patient, between information technology and the healthcare environment.
I think it is a game changer. It can aid the physician in.
Sounds great, right? It was a colossal failure. It was a colossal failure because the data that they used to train the models on were from Sloan Kettering and another and one or two other cancer institutions. And it wasn't heterogeneous enough. The information was too specific for those institutions. So the problem was when they saw these cancers, the treatments that they were recommended were the treatments that they knew, not necessarily the best treatments that were out there. So what they ended up doing is they dismantled Watson, and Watson went on to Jeopardy and won Jeopardy. But it failed. It failed, and IBM actually broke up Watson into, like, it was over $1 billion of an expense of what it came out to, and they sold it at a fraction of that $1 billion. So cautionary tale. It's not all great when it comes to AI. And, I think this is something we can learn from, that when you're looking at data from an institution, it's only that institution's data. There are attempts at getting shared data where the institution still owns the data, but that there's a way to share that across multiple institutions and even worldwide, right? So that's the hope of where we go, and that will accelerate, the research process. But that's where we are. So that is really gets me to the end of my talk, and really where we're going. It truly is transformative. I mean, this is significant technology. There's talk of a bubble of AI. I think it's here. I don't think it's going to change. We need to rethink the way we design assignments to be AI adjacent, so that we're not relying on the traditional ways of writing papers and taking tests. We have to think about oral exams and doing some different ways of evaluating students, so that we can ensure that they're critically thinking, and we're not giving that up to AI. And what's great is we could create this AI-driven personalized learning where it's going to give you questions that it knows you're weak in, right? You don't need to spend time on the stuff but it could actually focus and tailor to you questions and content that is specific for you. But we have to keep the ethical frameworks and think about some regulations as we do this. So thank you. I'm happy to take any questions you may have. And again, it's been a pleasure to be here. Thank you. Thank you.
Thank you so much for a wonderful presentation. My name is Maha. I'm the director for the PhD program, and we did a session where we talked to our PhD students about AI, and we also have here at Wayne State a safe GPT. I think it's Warrior GPT, where it will not store their own data, and that's important, I think, for a PhD student. But as an educator, so we have the detectors for AI, but we also have humanizing, programs where they look at your paper and make it look more as a human. So I want to hear your thoughts about that too. Thank
Yeah.
you.
Yeah, it's a great question. And that's the problem, because when I'm sort of building my ChatGPT response, I say, make it sound like me. Here's an example of 2 papers I wrote. Make it sound like this. So that's where I think we have to be mindful of alternative ways of assessing students' knowledge. And we're going to have to go back to oral exams. I know it's hard with some, like, if you're virtual, if you're asynchronous, but we're going to have to rethink this. And that's going to make our jobs as educators harder. But then why are we here, right? We need to be vigilant about it. I mean, we have to redesign curricula. We have to redesign assessments, and we have to do it cohesively as units as we go forward. So yeah, it's a concern, and we have to approach it in a way where students are not cheating, right? Students want to do well, and we want to help them do well, but we're not going to lean on this as a crutch. So let's redesign some assignments and not make it so easy to do it that way. Yeah, good question. Thank you. Yeah.
You hear okay?
Yes.
So first of all, I'm Garrett Rice. My mother is Virginia Rice,
Thank
and
you.
she would have loved this. She couldn't be
Awesome.
here tonight, but this is exactly the kind of thing she was hoping for.
That's awesome.
So thank you.
You're welcome.
A quick question. So I also work with AI.
Okay.
This was a fantastic presentation, and one of the things that I've come to realize about AI is it only exists in the computer.
Hmm.
It doesn't exist in the real world.
Right.
It's only mining data that's in the computer, right? And so you
Mhm.
talked about the recordings and that type of thing, right? So once it translates that, it deletes the original, and then any errors go on.
Right.
And so I'm wondering if part of the methodology that you guys are going to look at for nursing or for any education is the recognition of that and the ways to build policies and procedures so that the human beings recognize that they are the real world representation of what's happening with that information. Because I think that's probably the way we're all going to work with AI in the future. Is it can't smell the flowers, it doesn't feel sun on its shoulders.
Right.
And so I'm just wondering if anybody's talking about that.
Yeah, not enough are talking about it. And it's seemingly not enough is being done about that, right? Because if you ask a large language model, can you smell the flowers? It will say, yes, I can. And they smell great. So that's a problem. That's a problem. And, as we've evolved and, we type messages and, we know another person's on the other side of our phone, right? Because I'm texting my wife or my son or whatever, right? But ChatGPT gives the illusion that there's another person behind that's responding to you. So you're absolutely right. We need to think about that we're the human beings. AI doesn't care about you. It doesn't care at all, and it's very easy to forget that. And I think the software companies want you to think that they're the best thing ever, and we have to say no. But do we have the leadership right now to push back on that? It remains to be seen.
Stephen,
Yes.
thank you so much for coming today.
Yes.
I'm John Anderson, Associate Director of Marketing Communications for the
Yeah.
College of Nursing. Good to see you again.
Good to see you.
in person. Kind of a two-part question. When it comes to your specific role being the inaugural Associate Dean with the College of Nursing, A, why did Columbia want to create that position? And B, since you've started it, how has the role evolved as the technology has evolved?
Yeah, it's a great question. So it really flowed down from our president at the time, identified AI as a strategic initiative, and really charged each of the schools to own their area of AI. So I credit my dean to coming up with it. The funny story is, so I've always been involved in technology as like a passion, right? Not necessarily as my job. I'm a clinician at the end of the day. But I've always been fascinated by the technology. So I tell the story as that the dean had said, I'm gonna, create this new AI position. I volunteered to be on the search committee. And then 2 weeks later, she said, guess what? She said, you're it. I said, okay. So I kind of got it by accident by opening my mouth and volunteering for a position. They call that being voluntold. So that was the reason. So it came as a strategic priority that AI is here. We want each school within the university to be ready, AI ready. How has it evolved? In the beginning, like, where do you start? So that was my biggest challenge is where do you start? Because I had to get up to speed myself because it's constantly evolving, constantly changing. So it's been sort of like this dual process where I get up to speed and then I teach it to the faculty and students. So that's how it's been. As new updates come out, it's another workshop. It's another example of using AI. Fortunately, there are lots of coalitions, and I could give some examples of AI use in higher education. And there's like a lot of good work being done on it right now. But, the evidence is still being developed. And I think that's the hard part because we want to use it, but like, are the outcomes just as good? So to be continued. Yep. Hi. No.
What about now?
Oh, there you
Okay,
go.
Awesome. This is my first time with the mic. Thanks for coming today. I've been really looking forward to seeing some more meetings and hearing some more meetings like this. So my name is Brandon Rogers. I'm a first-year medical student here at Wayne State.
Awesome.
I have some experience with AI in my brief and illustrious naval career as an officer. So I have a basic understanding of the programming behind it. So I had a couple of questions, just
Sure.
quick ones, but
And thank you for your service.
thank you. So you had mentioned, you kind of touched on it, that issue with these businesses kind of creating an AI system and then having it, go on as a practitioner. So are there no rules in place, and have you seen anything even attempt to stop that right now? Because you could have, a nurse practitioner, a PA, physician, anyone just sign off on a program and say, this is an authorized, medical entity. So what's your experience with that, first off?
Yeah. Institutions are very conservative and cautious when it comes to agreeing to purchase a piece of software like a large language model. So right now, those are our checks and balances. What's to stop the rogue individual from doing it? I don't think there really is anything, but I know that at Columbia, it's a tripartite organization with Cornell and New York Presbyterian Hospital. So there is a huge team that is looking at every piece of, and it's not just AI, like we have to look beyond AI too, right? It's every piece of technology we use in healthcare. So those are the checks and balances right now that they're looking at.
Thank you. And then for AI and healthcare education, so how would you go about getting that spread and integrated into our like medical education now for nursing, PA, all of them?
Yeah. So from the student side or from the faculty side, or both?
I guess both.
Right. So, I mean, look, I think there are tools. On my screen was Google Notebook, right? Has anybody used Google's Notebook, Google Notebook LM? Right. So cool. Put your notes in there. It'll create a podcast that you can ask it a question. It's really cool, right? But the question I have is, are my students taking my notes that I created and uploading them into this model? And then what happens to my notes, right? So we're not having those conversations. So I think that's where students could use it and use it to be better students. And from the faculty side, I mean, look, when you have a class of 50 plus students, I can't give individualized feedback to every student, but AI can help me do that. So I think we have to lift up the veil and we say, I'm using AI, student, and student's gonna say, I'm using AI, professor. How are we going to use it in the best way? And that's where we have to start. So yeah, I think that's going to get us to where we need to be. Great questions. Yeah.
One of the questions that came up at in our leadership group at the Dean Suite was the whole notion of bias and ethics as it relates to AI. And I wondered who's really thinking about that? You know, if it's fed into material from existing literature, racism and bias and all that exists within the literature. So who's looking at that and thinking about that, I wondered.
Yeah. So those models that are being used specifically in healthcare, they are looking at that. Like the ChatGPTs of the world are not, right? Like this is a large language model that has lots of uses across many different disciplines. They're not necessarily looking at that, but those that are having specific uses in healthcare, they are looking at. But then we can get into the argument or the debate of, again, whether that information is not biased or it is biased. There's also ways to, sort of build small language models where they exist on, they're not going out onto the internet to find all the information. It's kind of, being trained on a certain set of data. It limits the responses it can give, but there's a way to correct for that. So I think that, and what I think we'll see more and more institutions not repeating the same mistakes as Watson, but creating a layer into the large language models where it will check for biases, right? Based on the research and the people who are doing the programming before it gives you a response. So I think that's our checks and balances, but we have to be the ones to say it. There are also nonprofits that are out there for the ethical use of AI, and they're putting best practices forward and frameworks forward. So we got to listen to them and incorporate them, but the work is being done. Yeah. Oh, you have the mic. You have a mic.
Yes, I have a mic. Thank you for an engaging presentation. Linda Wiglicki, I'm administrative and research consultant in the College of Nursing. With respect to, we've talked about the value of AI in healthcare, and one of the things that it keeps coming to mind, maybe I can just, keeps coming to mind for me is related to the tragic stories that you shared. And if the government's not doing as you suggest, who is educating and advocating on behalf of the patient, the family, and informal caregivers with the use of AI today?
No one. No one is
sad.
No one is advocating for the patients, and that's why, like, my whole approach has been AI literacy for healthcare people. But I think we have to be the ones to guide our patients, just because what we do in healthcare, right? But nobody's really doing it. I mean, there's patient advocacy groups that are out, but again, it pales in comparison. They have no money, compared to these big. I mean, these companies are hundreds of billions of dollars. It's, yeah.
Yeah, when you think of this generation, this younger generation who latches on to every piece of technology and utilization of it without knowing what the potential consequences are, we need to do a better job in that space.
100%. I mean, and we can debate about social media's role in that, and the instant gratification and notification and the constant on. I mean, that's a societal issue that we are all dealing with, and the ramifications in our youth is rampant. We'll go here and then we'll go there. So many questions. Thank you. Oh. No. But I'll repeat the question so you don't have to. Yeah. Mhm. Okay. Hmm. No, I mean, and total transparency, we're not. And, you know, it's hard to stay in front of it. What's happening is that there's so many AI factions within the institution itself. Like we're all doing our own AI stuff, but, and it's not to say there haven't been convenings and forums, but there hasn't been a lot of policy that has been generated from that has stuck. And I think that's the problem. So again, my plea to anybody who's going to listen to me, and you've been so great for listening to me for the last hour plus, is work on this. And I don't have the answer. I usually give a disclosure in the beginning. I feel like I've done a good job if you come away with more questions than answers. And because like this is happening in real time. There's no instruction manual for a large language model. Like this is now. So we can't ignore it. We have to be having the discussions about it. And we're gonna make mistakes. And it's okay. And I think if we approach it from that perspective, will be better. As far as the Google twice, I didn't even know I did that. But thank you for pointing that out. I'm gonna have to check myself on that. But no, it didn't mean anything. I mean, Google's been, you know, they're a major player in the space, but you know, they want to be everywhere too. You know, I mean, you don't even get a Google search with Google results anymore. You get AI summarized results, and that's another issue. So. Question. Hmm.
In some fashion to say, I don't know what side you can go for, but, you know, the question is only aspect of your
Yeah, it's a fierce two opponents here, right? The insurers who are looking to whittle back reimbursement and the providers that are trying to maximize reimbursement, and they're both using AI. So, you know, it's been reported, I don't know any details of it, but it's been reported that Medicare claims are going to have some AI assistance in that. I don't know if anybody knows what it truly means. I don't know, but it's going to be a battle, and there's other philosophical things that I could go off on a tangent, which I will not. But yeah, it's a good question. When, you know, AI can maximize productivity and billing and reimbursement, but then on the other side, they're going to try and pare that back. So again, another question. Yes. Hi. Mhm, mhm. Yeah, and thank you for bringing that up. I usually do allude to environmental aspect of the massive amounts of energy that these models consume to be run. I haven't heard any. Again, I don't claim to be the AI expert on everything, but I haven't heard it. What can happen is that these models can be run locally and in a way that is not energy dependent as the large model. So maybe that's the way to mitigate it, so it's locally run, it's not taking massive amounts of data. But the reality is, if we're condoning ChatGPT's use, what is our contribution to the negative side? The joke is when you talk to ChatGPT, don't say thank you, because that generates a response that is unnecessary because it's not a human. You don't have to thank ChatGPT. The other side of that is, well, when they take over, it's going to remember if you said thank you or not. But that's, again, well, you say thank you. Somebody gave you an answer. Oh, thank you for, but again, this is not a human being. So I think we have to have these discussions. And again, there's no instruction manual on these. So I think we have to try and put some guardrails and policies in place for our ethical use of it. Good question. Yeah. Yes.
So Nancy George, a professor clinical, but I'm also a clinician. And I have three things clinically related.
Okay.
One is I actually had a patient who I was using second language, Spanish speaking, was using a translator. And she Googled ways to commit suicide. And I will tell you that Google told her, put up a sign that said, here's the suicide hotline closest to you. So here's the good news. The other good news is she got help. The second thing that I see in AI is two things. The use of AI to deny pharmaceutical benefits. I had a patient who was a diabetic and AI denied her metformin. Now we all know metformin costs about $5. But I know it was AI that did that. So if you're a clinician and that's happening to you, this is what you do. You ask for a human being to look at it. Because the rate of prior authorizations is going up astronomically because of AI. The second thing is I had a patient look up symptoms using AI. So she came in to tell me that she was pretty sure she had dengue fever because she put all the symptoms into ChatGPT and that was the diagnosis it came back with. And I said, interesting. Have you been in South America, Africa, Southeast Asia? And the answer was no. And I said, then it's probably not dengue fever. So we worked her up. But I think this well enough. I still
Right. It's yes. And I'm sure if you poll people, right, there's going to be a percentage of the population that says, I don't care who gives me a diagnosis. I just want a diagnosis and I want as fast as I possibly can. Right. Like that can happen. That will happen. But we can't let it.
But the political side of it is what they did in Oregon, we need to do in Michigan.
Yeah.
Right. So that they cannot call
well,
somebody doctor.
They need to do it federally.
Well, that would be good.
But my hope of that happening, not so good. Sure. So they have they're students, right? So we try and work around their availability. But what's been interesting is that there have been a number of AI companies that have approached the School of Nursing, and they've been the ones to interact with them to sort of vet them, right? And they love it because they want to be all in technology. So they've been interacting and we bring that back to the school for demos. And again, we're not endorsing anything, but again, it's showing examples of what's out there and what can be done. So they've been interacting with some in industry. They've been advising on the concerns that they have had with some faculty that have been accusatory of, using the AI detectors when they didn't. So we've been having some interesting discussions to have that facilitated dialogue. And that's been primarily their role. They were also like ambassadors for AI. So I've held, I don't know if I had that on my slides. I might have taken it off, but we did like a genius bar in the lobby of the School of Nursing, right? I set up a computer with a screen and said, ask me a question about AI. And people will ask, right? Because they're there. So it's been a way to socialize AI and have that discussion and I'm going to say force those discussions amongst the community, which I think we have to do, right? Because again, we're going to be the ones using it, instructing our patients on how to use it. Like it's not Dr. Google anymore, right? Where, you vague symptoms and it could get much better. So we can't necessarily blow that off. But again, how can we use it together better? Yeah. Thank you.
Very exciting.
Thank you. Thank you. Thank you. Thank you. Thank you so much.
Out in the lobby, please. Your conversations and questions out in the lobby, and Dr. Ferrera will be here with us. So thank you all very much for attending.
Thank you. Thank you.
And yeah. There.
Mind if I stop you recording? Okay.